Good morning, everybody. I'm Hugh Hagan, orthopedic hand surgeon in the hand surgery section of Carilion Clinic, Department of Orthopedics, affiliated with the Virginia Tech Carilion School of Medicine. And my job this morning is to present to you benign masses and tumors of the hand. Some of the images and text taken from ASSH Crucial Elements of Hand Surgery PowerPoint presentations. I have no disclosures. The goals of this talk are to review the diagnosis and treatment of the more common benign masses and tumors of the hand. Take-home messages from this talk include most hand tumors being benign can be treated by excision with favorable prognosis. You should beware of uncommon, benign-appearing malignant tumors. And you should always be safe. You should biopsy all infections and culture all tumors. When treating tumors, you should plan incisions carefully with definitive surgery in mind if the lesion turns out to be aggressive or malignant. And you should consider early referral for tumors that may be malignant, particularly if you have limited experience dealing with them surgically. We will begin by looking at soft tissue benign tumors and benign bone tumors. Benign soft tissue tumors include ganglion cysts, epidermal inclusion cysts, lipomas, giant cell tumors of the tendon sheath, vascular tumors, and nerve sheath tumors. We'll start with ganglion cysts. In general, these are the most common hand tumors. They're more common in women. They can experience either rapid or gradual development, and they generally arise from a joint capsule or a tendon sheath. They can be post-traumatic in origin. They can be a result of arthritic degeneration. They can be associated with a synovial herniation. The diagnosis of ganglion cysts, on clinical examination, they tend to be mildly tender or not tender at all. A mass will often transilluminate, and this will separate the ganglion cyst from many other benign masses around the wrist and the hand. They can be associated with osteoarthritis or a synovial cyst. They may be pulsatile around the wrist due to proximity of the radial artery. Ganglion cysts can be located on the dorsal wrist, most commonly at the scapholunate interval, on the volar wrist at the radioscaphoid and scaphotrapezial joints, which are the next most common. And there are other common sites, such as the thumb carpometacarpal joint, the flexor carporadialis tendon sheath, associated with STT arthritis in many cases, the distal palm or proximal digit, and the distal interphalangeal joint, otherwise known as a mucus cyst. Cysts can present in enclosed locations, such as the carpal tunnel or in Guillen's canal, and produce secondary nerve compression syndromes. They can exhibit a local mass effect, such as this example taken from the Hand Society's instructional lecture on ganglion cysts and tumors, in which a ganglion cyst is present in Guillen's canal. Diagnosis is also based occasionally on imaging studies. Radiographic assessment is usually normal unless the cyst is associated with arthritis. MRI can be useful to identify occult ganglions as a source of local symptoms, particularly on the dorsum of the wrist. And ultrasound is becoming a more useful tool for assisting in the diagnosis of ganglion cysts. Treatment of ganglion cysts can be observation, splinting, aspiration with or without steroid injections, rupture, as in with a book, which works reasonably well with dorsal carpal cysts and surgical excision. Aspiration of ganglion cysts with or without steroids combined with splinting might be successful in some patients, but it really meets with rather limited success in my practice. It is possible that you can use this as a temporizing measure. For surgical treatment, you want an operating room or dedicated treatment room setting. And the anesthesia can be anything from straight local with epinephrine to a general anesthetic with a tourniquet. Recurrence following surgical excision is rather uncommon in single-digit percentages, as long as you are appropriately aggressive in taking the lesion out and including its base or stalk, as well as a cuff of joint capsule or tendon sheath from which the cyst arises. The results of arthroscopic excision of ganglia from the wrist joints are equal to open excision. Surgical treatment for volar retinacular cysts, which arise from the flexor tendon sheath, needs to be tempered by the knowledge that these can spontaneously resolve in over half of the cases. If you aspirate it, about 2/3 of them will go away completely. And in surgical treatment, there's a very minimal recurrence as long as you excise the cyst and its origin with a patch of the flexor tendon sheath. Typically, if you excise one of these with the tendon sheath and turn it over, you'll see the little hole from which the cyst arose. Mucus cysts are ganglion cysts. They arise at the distal interphalangeal joint of the finger or the thumb. They typically occur in older patients, excuse me, and they're often associated with osteoarthritis. There's often a nail groove that's caused by compression of the nail matrix by the cyst resting on the germinal matrix of the nail proximally. The cyst may cause attenuation of overlying skin. It's usually on the dorsum of the finger, and it's usually lateral to the extensor tendon. Spontaneous or patient-directed drainage may have occurred, as in I used a needle that I sterilized with a match. Sometimes these patients will present with an infection. When you get an x-ray of a patient with a mucus cyst, more often than not, there'll be some degree of osteoarthritic change in the DIP joint. Usually there'll be some osteophytes present. Excising a mucus cyst can be anything from making a small incision, elevating the skin and removing the cyst, all the way up to excising the cyst, surrounding skin, debriding osteophytes, and rotating a small dorsal flap, as is seen in this example. Usually the flaps can be developed by first creating a triangular defect that includes the cyst and its underlying joint capsule, and then mobilizing a local skin flap at the level of the peritoneum. Debridement of osteophytes is also important. And in fact, if you have a very distal cyst, one that you don't want to make an incision over, you can simply go for the DIP joint, expose the origin of the cyst on one side or the other of the extensor tendon, excise the capsule there, and then remove the osteophytes, and typically the distal cyst cavity will involute. Epidermal inclusion cysts can present anywhere. They are slowly enlarging, tend to be well circumscribed, and are common in the distal finger. They are generally the result of some epithelial internalization. Usually there's a penetrating injury of some sort, a splinter wound, a laceration that was untidy, and a bit of growing skin is implanted deep and then healed over. Keratin secretion is deposited subcutaneously. And these cysts can sometimes be so slow growing and involve such pressures that they can create osseous involvement, like this picture from the Hand Society's instructional lecture, where you can see well defined discrete invasive lesions of the bone. Sometimes biopsy may be indicated in the case of one of these cysts because it looks almost like a lytic lesion, as might be seen from metastatic lung cancer. Typically, a epidermal inclusion cyst can be treated effectively with complete excision of the cyst and wall. The cysts include this friable white material, which is just basically contained keratin. And the lesions can be small, a few millimeters in size, or they can be larger. Once they're excised, the recurrence rate is very low. Giant cell tumor of the tendon sheath is also a common benign tumor of the hand. It is the second most common soft tissue mass after a ganglion. Histologically, it is very similar to villonodular tenosynovitis as is seen in the knee. It is found in synovial fluid producing areas such as tendon sheaths, joints, capsular ligaments. They tend to be very slow growing. They're somewhat lobular, non-tender, and when viewed grossly, they have this appearance. There's sort of a mixture of brown, tan color. They're usually fairly smooth. They often originate in the DIP joint of the finger, and they can be confused with a ganglion cyst because of their location, but remember, they do not transilluminate. They're solid, not cystic. You can see in this particular case of a giant cell tumor of the DIP joint, as it grows, since it's growing from a deep location, particularly if it presents volarly, it will carry all of the more superficial structures superficially. So if you're excising a giant cell tumor from the distal finger and there's a volar component, you have to be aware of the fact that the nerve and vessel may be immediately beneath the skin, being pushed up by the cyst, by the mass itself. And giant cell tumor pathology, and this occasionally comes up on an exam, is marked by histiocyte proliferation, lots of hemosiderin, and multinucleated giant cells, as is seen here. The treatment of a giant cell tumor is marginal excision. The risk of recurrence is wide across the board, 5 to 50% in various studies. And I think a lot of this simply depends upon the point of origin of the lesion. For instance, if it arises in the DIP joint, the only way to get to the entire tumor is to open up the DIP joint. And sometimes that's more than you want to do. Joint arthrodesis may be indicated if you have extensive joint involvement or a recurrent giant cell tumor. Another common mass seen in the hand is a lipoma. Lipomas are very common benign fatty tumors. They are non-tender, they tend to compress, but once again, they don't transilluminate. They can present in locations typical for a ganglion cyst, such as the dorsum of the wrist. And I recently saw one of these and was fooled by the diagnosis, thinking that it was likely a ganglion cyst. Couldn't really tell if it transilluminated or not, but when I opened it up, it was clearly a lipoma. X-rays may demonstrate a soft tissue shadow or mass, but are otherwise generally non-diagnostic. Other imaging can include MRI, which is very characteristic for fatty tumors, and can differentiate the lipoma from surrounding fat. And the location of the lipoma in the hand or in the upper extremity can be, excuse me, significant as it can produce local nerve compression or vascular compression syndromes. If the appearance on MRI is uncharacteristic, an incisional biopsy may be necessary for deeper lesions. I've seen some very large lipomas in the arm that behaved in a somewhat scary fashion, but these turned out to be benign in most cases. They can be any size, but generally they have well-defined margins, very discrete. They're generally easy to excise depending on their location. And the primary indication for excision is usually just progressive growth or functional impairment due to location. Vascular tumors in the upper extremity, benign vascular tumors, mainly two. Glomus tumor. Glomus tumor is benign, and it is frequently subungual, but not always. I've seen them in many locations, in the hand and in the arm. Lesion is formed from a glomus body, which is a neurovascular microorgan which exists in the pulp of the finger, which regulates blood flow. It's located in with less frequency proximally. The classic symptom triad is intermittent significant pain, significant point tenderness, and cold intolerance. Those three things make the diagnosis. If a person has a glomus tumor, they will not let you get anywhere near it to touch it. Oftentimes, if these present beneath the nail, there'll be a bluish discoloration. MRI can be very useful to identify the lesion if you have somebody whose clinical presentation strongly suggests a glomus, but you're not quite sure on physical exam if there is a glomus tumor present. Glomus tumors are treated with surgical excision. If they present beneath the nail plate, a longitudinal incision can be made in the sterile matrix and the tumor excised without sacrificing the nail plate. Larger defects may require a wider area of excision and split thickness skin grafting or nail bed grafting, but I've never had to do that. Here's an example of a procedure preserving the nail plate with a glomus tumor under the germinal nail matrix, elevating a distally based flap that incorporates the eponychium. And the appearance of the tumor on the right side of the photograph is very characteristic. It's shiny, sort of like a pearl, very well circumscribed. Here's another one that a patient of mine who had a glomus tumor presenting volarly, lots and lots of tenderness in the pulp of the finger, an MRI that showed a lesion, negative x-rays. These are surgical pictures. The upper left, you can see the glomus tumor. In the lower right, you can see the glomus tumor after excision, and lower left, the cavity that was actually pushed into the bone by the slow growth of this lesion. This patient had classic symptoms for 10 years. This patient been given numerous diagnoses, from carpal tunnel syndrome to arthritis. The x-rays were normal, though if you go back and look at them carefully, you can see a little bit of erosion volarly. The MRI was diagnostic in this case. And once these things are excised, generally there's complete relief of symptoms. Pyogenic granulomas are common vascular lesions of the hand following local trauma. There's an overgrowth of granulation tissue. It's very friable. It bleeds easily. It's often a very messy thing, particularly if it's already been treated with silver nitrate. Then it tends to bleed frequently and be black in appearance. The treatment of pyogenic granuloma can be the use of silver nitrate on very small lesions. This can be successful, but on a lesion this size, it's pretty disappointing. I think the use of silver nitrate, the intent is to desiccate the lesion, but oftentimes it just irritates it. I tend to excise them with a small skin margin. Recurrences are very rare. Common nerve sheath tumors, schwannoma and neurolymoma, and neurofibroma. Schwannoma or neurolymomas are most common benign nerve tumor in adults. They tend to arise from the Schwann cell. They're not intraneural per se or intraaxonal. They grow very slowly. They're very well circumscribed. They tend to be eccentric on a peripheral nerve in that they arise peripherally, not centrally. And nerve fascicles do not enter this lesion. The lesion is derived from the nerve sheath, and thus the nerve fascicles make their way around it. Excising a schwannoma is usually fairly straightforward, regardless of the size. The lesion can simply be shelled out of the nerve body. In the case of a digital nerve or a smaller nerve, the use of a microscope can be helpful. Sometimes these lesions are larger, and loop magnification would be sufficient. They oftentimes present in older individuals. They generally don't hurt, but they may be very sensitive, and there may be an associated neurological deficit. It tends to be mobile transversely, but not longitudinally, and because it's anchored in its axial motion by the nerve itself. And recurrence of these lesions following excision is very rare. Malignant transformations, extremely rare. Neurofibromas are also peripheral nerve tumors, but they're different. They develop within the nerve fasciculi, and thus actually replace viable nerve. Excising a neurofibroma and sparing the function of the nerve is very difficult, though in many cases, nerve function is already deteriorated by the time a neurofibroma is noticeable clinically. Surgical excision usually requires division of nerve fascicles that enter and exit the lesion. And so for essential nerves, nerve reconstruction will need to be planned either as a primary or staged procedure. There is a recognized risk for malignant transformation in neurofibromas, particularly in patients who have neurofibromatosis, but this is a rather rare entity. So we will move now into benign bone tumors. These include enchondromas, osteochondromas, osteoid osteomas, aneurysmal bone cyst, and giant cell tumors of the bone. Enchondromas, they are benign cartilaginous lesions. They are intraosseous. They account for about 90% of all bone tumors in the hand. They are seen in younger patients often. There can be multiple enchondromas or enchondromatosis that usually presents at an early age. The proximal phalanx is the most common location, followed by the metacarpal middle phalanx, and the wrist bones themselves are rarely involved. Patients will usually present following a pathologic fracture because these tend to be completely asymptomatic during the course of their growth until a fracture occurs. Sometimes they're discovered incidentally on an X-ray. X-rays will show a very well-defined lesion within the bone with a very thin sclerotic border. Typically involves a metastasis of the bone. There's usually some calcification, as is often noted on any calcified tumor or cartilaginous tumor. And soft tissue extension and periosteal reaction are very rare. These are slow-growing lesions. They do not really affect the bone unless there's a fracture. Grossly, they look like cartilage. And microscopically, you see chondrocytes with bone and calcifying tissue. Malignant transformation of an enchondroma is extremely rare unless you have a patient who has enchondromatosis. And there's about a 30 to 50% chance that at some point in their lifetime, they'll develop a chondrosarcoma. Treatment of enchondromas, generally small asymptomatic lesions, these can be observed unless they produce a problem. Larger or symptomatic lesions can be surgically treated, and pathologic fractures associated with these lesions can be allowed to heal prior to treatment of the tumor itself. Resecting the area with curettage and bone grafting, either allograft or autograft, is accepted treatment. I think you could possibly curette one of these and just leave it alone and let it heal, although the bone stays weak for a longer period of time if you handle it that way. Risk of local recurrence extremely small. Osteochondromas are similar cartilaginous lesions that develop outside the bone, typically in the region of prior physis, most often found at the distal aspect of the proximal phalanx. They typically present in younger patients, and they have a cap of hyaline cartilage. They are thought to originate from the physis. They can result in some cosmetic deformity, usually angular, or a visible or palpable mass. You can have a growth disturbance in a child. Microscopically, well, grossly, they tend to be bony lesions with a cartilaginous cap and a stalk of mature bone surrounded by a normal appearing periosteum. And microscopically, they're just healthy looking chondrocytes overlying a stalk of lamellar bone. Oftentimes, the core contains marrow and mature trabecular bone, which is one of the differentials when you're looking at one of these lesions microscopically. Oftentimes, chondrosarcomas have a rather benign appearance microscopically, but if it's seen adjacent to lamellar bone with a normal appearing trabecular bone, as you'll often see on an exam, that makes the diagnosis. The treatment of osteochondromas is marginal excision, and malignant transformation is extremely rare, and at least when I did this talk, it hadn't been reported. Osteoid osteomas are benign bony lesions. They are fairly common in the wrist and hand. About 15% of them occur in the wrist and hand. They tend to show up in younger patients. And the symptoms, which are usually just focal pain and tenderness, are relieved by classically aspirin, but non-steroidal anti-inflammatories. Radiographic findings include a reactive sclerotic ring with a central nidus. Usually the ring is rather small and discrete. There may be thinning or overgrowth of the overlying cortex. And you can use a CT scan to improve diagnostic accuracy because it will fairly clearly show that dense, bony nidus that is characteristic of an osteoid osteoma. Another X-ray here with thickening of the cortex. Surgical excision with curettage of the nidus or en bloc resection is the treatment of choice. Aneurysmal bone cysts make up 5% of all benign tumors, but only 5% of them are in the hand. So they're rare lesions, particularly in the hand. Almost always they're in younger patients. Almost always there's going to be some degree of swelling. They may hurt or they may not hurt. And the metacarpal location is more common than the phalanx, as opposed to the enchondroma, where the proximal phalanx is more common than the metacarpal. But as in the enchondroma, it's rare in the carpus. Multiloculated blood-filled cavities is what you're going to see histologically. You may see that on an exam. And also these cavities are not lined by vascular endothelium, so you can think of them like a false aneurysm. Soft tissue lesion, soft tissue vascular lesion with no vascular endothelium. It's false aneurysm or pseudoaneurysm. And a bony blood-filled cavity with no vascular endothelium is an aneurysmal bone cyst. Imaging, oftentimes a plain X-ray is going to make your diagnosis. MRI, CT can be useful to look for cortical breakthrough or destruction, or soft tissue extension, which might suggest another etiology for the lesion. Treatment can be difficult because oftentimes these lesions can progress to an extensive degree and replace an entire bone. If the lesion is focal, curettage and bone grafting may be adequate. I've read a lot over the course of my career about various adjunctive treatments, cryotherapy, bone cement. I'm not sure of any study that really supports one over the other or gives solid advice regarding their use. Wide resection of the lesion might be necessary if you just don't have anything to build on. And recurrence rates with marginal excision can be pretty high, up to 60%. Giant cell tumor of the bone is a benign tumor. However, lesions can be locally aggressive, and they can metastasize to the chest. They occur in middle life, and the distal radius is the third most common site in the body. You can see them in metacarpals in the hand. Oftentimes there'll be a lytic lesion. It won't have distinct borders. There may be some cortical breakthrough, which is distinct from aneurysmal bone cysts. There may be soft tissue expansion, and tumor grading can be assigned just by partially by assessment of the integrity and quality of the cortical margins. In other words, the more aggressive lesions create more rapid growth and bony destruction. Seen on the CT scan, you can see the cortical damage. They make up 5% of all benign bone tumors, but only 2% of them occur in the hand. So once again, pretty rare, sort of like aneurysmal bone cysts, to see a giant cell tumor of the bone in the hand. They have a higher risk of local recurrence after treatment simply because excision tends to be less forgiving in the hand. You have less tissue to work with. Local recurrence rates can be as high as 80% following simple curettage and adjuvant treatment. When treating a lesion like this, incisional biopsy is indicated, and if you do so, you want to make sure that your biopsy incision can be incorporated into a stage to reconstruct a procedure or an amputation. And staging the tumor includes the usual tumor workup, a chest CT, possibly a bone scan. The treatment of choice of a giant cell tumor of bone is surgical resection. If you have a contained lesion, then curettage, adjuvant treatment, and bone grafting of the lesion may be acceptable, even though it has a high recurrence rate. And if you have a non-contained lesion, it can be treated with amputation or an en bloc resection and subsequent reconstruction. This example seen on the previous slide was treated with an en bloc resection and iliac crest graft with fusion of the basal joint. So, take-home messages. Most hand masses and tumors are benign. They can be treated by excision with favorable prognosis. You should be aware of uncommon, benign-appearing malignant tumors. And by all means, be safe. If you're not sure about a lesion, you can refer early. If you're dealing with something that's an infection or a tumor, just be sure to culture and biopsy both. And anytime you perform a surgical procedure on a tumor in the hand, you need to think carefully about where your incisions are placed and keep in mind the possibility of later definitive surgery. Thanks very much.